Good morning, everyone. I am Dr. Rohit Kumar from Sri Lakshmi Narayana Medical College, Pondicherry. My topic is chronic recurrent multifocal osteomyelitis. My co-authors are Dr. Nitish Kumar Yashlawat, our professor and HOD, Dr. Nanapriya, assistant professor, Dr. Priyan Volte, associate professor. CRMO is a rare autoinflammatory bone disorder characterized by sterile multifocal bone inflammation and relapsing pain episodes. It presents mainly in children and adolescents, usually between 4 and 14 years of age. The female to male ratio is approximately 2:1, with incidence roughly around 1 per 10 lakh cases. It is considered a diagnosis of exclusion after ruling out infection and malignancy. It has association with other inflammatory disorders, example psoriasis and inflammatory bowel disease. Presenting symptoms include chronic bone pain, which is gradual in onset, local swelling with or without tenderness, and mild fever or malaise can be present occasionally. The aim of this study is to describe imaging findings of CRMO, typical anatomical distribution, to highlight key radiological features that help distinguish CRMO from its differentials. Material methods. All cases referred to the Department of Radiology in Sri Lakshmi Narayana Institute of Medical Science, Pondicherry. All MRIs are done using 1.5 Tesla Siemens magnetome Essenza. On MRI, T1, T2 and stir images are taken. The imaging parameters assessed are lesion location and distribution, signal characteristic on MRI, and presence and absence of abscess, sequestrum, and soft tissue mass. So this is case 1. A 60-year-old male came with the complaints of pain in bilateral knee for 2 months. These are the images of right knee, T1 and stir coronal images showing multifocal scattered areas of abnormal bone marrow edema-like signal intensity of varying sizes in distal femoral and proximal tibial metaphyseal and condylar region. These are the images of left knee, stir and T1 coronal images. And this also, there are multifocal scattered areas of abnormal bone marrow edema-like signal intensity of varying sizes in distal femoral and proximal tibial metaphyses, as well as condylar region and tibial spine. So this is the next case. A 9-year-old female came with the complaints of back pain, right hip pain, and right leg pain for 1 year, which were aggravated for 1 month. In these coronal stir images, we can see multifocal stir hyperintensity involving the right brim and bilateral sacroiliac joint. And those hyperintensities are also involving bilateral acetabular surface, predominantly cartilaginous region and quadrilateral plates, and pubic symphysis. So on whole spine screening, we can see multifocal T2 hyperintensities noted involving vertebral bodies in cervical, dorsal, as well as lumbosacral region, predominantly around the end plates. These are the stir coronal images showing multifocal hyperintensities involving vertebral bodies, predominantly around the end plates. So further workup, whole body MRI, it detects multifocal and clinically silent lesions, helping confirm CRMO. It is highly sensitive for early marrow edema and disease activity. There is no ionizing radiation, so it is ideal for children and for follow-up. It helps differentiate CRMO from infection or malignancy and monitor treatment response. Bone scintigraphy, it detects multifocal and clinically silent lesions. It is useful to assess disease extent. It can be negative in low disease activity. CT, it demonstrates cortical destruction, sclerosis, and periosteal reaction. It is useful in complex anatomical areas like spine, sternum, and pelvis. And the radiation exposure limits routine use. Biopsy is performed when diagnosis is uncertain, and it helps exclude malignancy and infection. Results of this study, age and gender, which are most commonly affected, was adolescent female. Duration of symptoms were of several months. Presenting symptoms include insidious localized bone pain, local swelling was occasionally present, and systemic symptoms were mild or absent, and ESR and CRP was mildly elevated, while WBC count was normal and blood cultures were negative. Number of lesions were multiple, and the most common site affected was long bone metaphysis with diphyseal extension, and clinical silent lesions were present. Discussion. Chronic recurrent multifocal osteomyelitis is a rare, non-infectious inflammatory bone disorder that predominantly affects children and adolescents. with a female predominance. The etiology is unclear, but genetic, autoinflammatory, and autoimmune mechanisms are suspected, supported by familial cases and associations with conditions such as inflammatory bowel disease, psoriasis, and SAPHO syndrome. Clinically, CRMO presents with chronic relapsing bone pain and swelling, with the lesions that may be solitary or multifocal and synchronous or metachronous. Laboratory findings are non-specific, typically showing elevated ESR and CRP with normal WBC counts. Long bones are the most commonly involved, particularly the metaphysis, though other skeletal sites may be affected. Imaging plays a central role in diagnosis. Radiograph shows evolving lytic lesions that later progress to sclerosis and hyperostosis. Bone scintigraphy is valuable for detecting multifocal and clinically silent lesions. MRI is the most useful modality, demonstrating bone marrow edema in active and sclerosis in quiescent phases, with the absence of abscess or sinus tract formation helping to differentiate CRMO from bacterial osteomyelitis. CT has a limited role due to radiation exposure. CRMO remains a diagnosis of exclusion, often mimicking infection or malignancy such as Ewing sarcoma. Management is primarily medical, with NSAIDs as first-line therapy, while antibiotics are ineffective once the diagnosis is established. Despite its aggressive radiological appearance, CRMO is a benign and usually self-limited condition, and early recognition is essential to avoid unnecessary invasive investigation and overtreatment. Differential diagnosis for CRMO includes acute bacterial osteomyelitis, which will have abscess and sequestrum, Ewing sarcoma, that will have aggressive periosteal reaction and soft tissue mass, LCH, which will have punched out lytic lesions, leukemia will have diffuse marrow involvement. Inclusion: CRMO is a diagnosis of exclusion with a characteristic imaging pattern. MRI and whole body MRI are cornerstone modalities. Awareness of radiological features enables early diagnosis, reduced invasive procedures, appropriate clinical management. These are my references. Thank you.